Yeah, good evening, Dr. Rohit. Can you hear me? Hello.
Sir, you are well heard, sir.
Okay, thank you.
Is there a problem at my end?
There is some resound coming from your.
Okay,
Actually,
actually,
I am from 2 points.
Yeah, your login from.
so actually my laptop is not working, so I will do it from phone only.
Good evening,
Okay.
Dr. Sanjay.
Good evening, respected teachers, sirs, Dr. Surya,
Good
everybody.
evening, sir. Good evening.
Nice to
Good
see
evening.
you.
Good evening. Thank you for the opportunity. Thank you for inviting.
Yeah, thank you. So your shelves are filled with awards, mementos.
These are not allowed anywhere else at home. So these all, the small room is just, the walls are converted to this, nothing else. This is what you give to somebody, we keep it here.
Yeah, nice.
Nothing major about it. Good, congratulations on organizing this. You were still in the
Yeah,
operating room. I just changed and came down. I said,
I
let's
said
sit,
okay.
let's sit with all of you.
Nice.
How does it look like? Dr. Rohit, good evening. How does it look like?
No, it's looking great. Just it.
Dr. Taneja, good evening, sir.
Hi, good evening. How are you?
Good evening, sir. Good evening.
Good evening.
Actually, I think I have to call Pawan. He is stuck up in airport. I will just remind him.
Oh, good evening, Dr. Rajesh. Good evening.
Hi, good evening. Good evening.
Good evening, sir. So
Hi,
we just meet Dr.
Pranita.
Hi
Good evening.
everybody, good evening.
Dr.
Good evening, ma'am.
Keshavamurthy sir has not joined. No? Just remind.
Ma'am, good evening. Sir, good evening.
Good evening,
Good evening, Dr. Pawan. Good evening.
Pawan has joined.
Hi.
Pawan has joined.
Sir, good evening, sir. Sir, yes.
So we are in Zoom and others will log it through USI e-learning portal. Am I audible to Navneet?
Yes, sir. Good evening, sir.
Uh-huh. I think we will start at 7:30 sharp, no?
Okay, sir.
Dr. Rohit, Dr.
Yes, you were saying something, Dr. Surya?
Keshavamurthy is busy. Yeah. We'll start another. Dr. Keshav said he will join little late. So we'll start.
Okay.
Even Dr. Uttam is also said he'll join little late.
गुड इवनिंग एवरीवन। रोहित कैसे हो?
बस बढ़िया।
आज भी डिनर पे गए हो?
नहीं आज डिनर आज कितना पहले से शेड्यूल था।
मिलेंगे। अरे तू डिनर बहुत करता है तो तेरे को आगे पक्का मिलेंगे।
कभी भी आओ यार, एनी टाइम। नवनीत, आप मेरा पहला जो प्रेजेंटेशन है उसको लोड कर दो। आई थिंक सो दैट वुड बी बेटर। मिस्टर नवनीत।
Okay. Shall we start? 7:30 now.
यस नवनीत जी, आप मेरा पहला जो प्रेजेंटेशन है वो अपलोड कर दो, शेयर कर दो।
So very good evening to all of you. I welcome you all for this today's smart learning session on interstitial cystitis and bladder pain syndrome masterclass from diagnostic dilemma to precision medicine. I'm Dr. Surya Prakash, Chair in the Indian School of Urology. So as you are all aware, we are doing these smart learning programs every month, once or twice, to keep ourselves updated, and also these are all teaching sessions for our postgraduates, very useful sessions. All these sessions are recorded. If somebody has missed, they can watch again, going to the learning platform. I welcome all the distinguished faculty, Dr. Anita Patel, Dr. Rajesh Taneja, Dr. Sanjay Pandey, and Dr. Pavan Vasudeva. As you all know, ICBPS is one of those conditions that continues to challenge even the experienced urologists. Patient has symptoms, investigations are inconclusive. We often ask ourselves, is this UTI or is this ICBPS or is this some other condition? So to answer all these questions, we have designed a very interesting smart learning session today. So at the end, we have a very interesting panel discussion where I hope we discuss real world problems that we encounter every day in our clinics. So I request all the participants to actively involve in the session, ask questions through the chat box, and make the session more interactive. So now I request Dr. Rohit Upadhyay, moderator of this session, to start the session. Once again, welcome all the faculty and the participants. Over to you, Dr. Rohit.
Good evening, everyone. I'm really thankful to USI for giving me this opportunity. And I'm also thankful to all the consultants, Dr. Taneja, Dr. Pandey sir, Dr. Anita Patel, for really agreeing and participating in this wonderful webinar. So without wasting much time, I will start. Nandini, you keep on changing the slides.
Dr. Rohit,
Yes.
Sorry to interrupt you. Dr. Uttam Mite has joined. Sir, I thought is not there. Sir, welcome. I welcome you for this webinar.
Good evening, sir. Good evening.
Good evening. Sorry, Surya, I missed your call.
No problem, sir. Your opening remarks before Dr. Rohit starts.
Yes, so Mr. Navneet, keep on changing the slides. It's just a 5-minute talk. So I think without wasting time, I think everybody understands that interstitial cystitis or bladder pain syndrome or chronic pelvic pain syndrome is a very confusing topic. I think it is one topic which really confuses everyone because you don't know what the treatment is. And even when you know what the treatment is, the results are not very good. The incidence is around 0.1%. Females are greater than male. But I think most people will agree that even male patients suffer like anything with this disease. Navneet, next slide, please. And it is a very large umbrella. Interstitial cystitis may not be the same as bladder pain syndrome, and it may not be same as the chronic pelvic pain syndrome. But they have got overlapping features, and there are different phenotypes to the same phenomena, which can exist in too many different forms. So that's why this webinar is important because we'll really unravel all the what the phenotypes are, what are the diagnostic tests, and what are the various treatments according to different phenotypes. Next slide, please. So we have got a lot of questionnaires. I will not go in detail, but we'll really dig onto our consultants to really know what is latest in the evaluation of bladder pain syndrome and interstitial cystitis patients. Next slide. And what we presently need is a phenotyping of this patient's multidisciplinary approach. And we really need to make sure that the treatment is individualized and the patients have a realistic expectations. Because even after a lot of deliberation and a lot of thinking, everybody will agree that all patients are not relieved completely. So a realistic goal setting is very important. And that is what we are going to learn in this session. Treatment are many, behavioral treatment is there, psychosomatic treatment is there, all various kind of treatment is there. Some have got very good effect on some of the patients and rest of the patients keep on suffering. So now we'll see what our experts are saying in this regard. Thank you very much. So I think now the next speaker will be Dr. Anita Patel, who will be deliberating on the differential diagnosis. Hello, am I audible? Yes. Hello.
Yeah, Dr. Rohit.
Yes. So,
Madam, are you ready with your slides?
Yes, just give me a minute. I'm just sharing the screen. Is my screen seen?
yes.
Yes, but it's not full screen.
Okay. No, you
maybe.
will see it now. Just a minute. For some reason. Yes, there we go. Okay.
Yeah, fine.
Okay, so at the outset, I wish to thank USI as well as ISU and Dr. Rohit Upadhyay, who's the captain of the ship for this particular course, to ask me to cover the diagnostic part. I have deliberately kept the title as ICBPS plus minus pelvic floor dysfunction. As we all know, and as has been clear from the introductory slides by Dr. Rohit, that there's nothing black and white about ICBPS patient cohort. And just as diagnosis has a lot of blurred lines, even the management has similar features. So let's see what clinical diagnostic features do we encounter in patients who are thought to be having ICBPS. So we do know the definition, and for the benefit of everybody, I'm putting the definition which was proposed by International Continence Society, and that is a persistent or recurrent chronic pelvic pain, pressure or discomfort perceived to be related to the urinary bladder, accompanied by at least one other urinary symptom such as an urgent need to void and or urinary frequency. And we always add in the absence of any known pathology, including UTI, and of a duration which is at least for 6 weeks or longer. The original term used to be interstitial cystitis, and I remember during my training in urology, we used to get those AUA teaching sessions in which there used to be leaflets which used to come along with AUA clinics. And it used to be followed by multiple choice questions, etc., etc. So there was a huge amount of literature on interstitial cystitis. We didn't call it by the term BPS. And not only that, we know there is a World Interstitial Cystitis Society also. The term BPS is now preferred because the original term IC assumed that every patient showed features of inflammation. However, we still use the term IC in patients who are known to have Hunner's ulcers. Often underreported, as Dr. Rohit mentioned, seen more commonly in women, and the statistics is there in front of you. The various etiological theories are presence of transmural bladder inflammation. The triggering factor or the inciting factor of that is multifactorial. The trigger could be a simple single episode of UTI, for example. And if one were to take biopsies, especially in especially in patients who show features of inflammation and Hunner's ulcers, the biopsy is classically described as showing mast cells with depletion of GAG layer or glycosaminoglycans layer, making the bladder more vulnerable to both microbiological or chemical irritants. In fact, the initial urothelial impairment is what leads eventually to a cascade of symptoms. And there are people who believe that if we catch these patients during the initial urothelial impairment stage, we can actually disrupt this cascade, which otherwise can lead to an incessant cycle of pain, often associated with pelvic floor spasms, so on and so forth. Typical Hunner's ulcer, though not seen very frequently, would show the features which I have just mentioned. It is believed that the management of patients with an ulcer is a little more difficult, but with multidisciplinary treatment, the management can be more structured. The most important line is the last one, and that is the disease almost never leads to major renal damage, or it's not a precancerous condition. So what is the typical clinical presentation? Presentation can be bladder-centric or it could be pelvic floor-centric. So a patient would have storage LUTS with pain which could be in one of these areas: lower abdomen, pelvic region, periurethral, perineal, and relieved partially or completely after voiding. Those who have pelvic floor-centric symptoms may have associated voiding LUTs. If it's a female patient, she may describe dyspareunia, and there may be other symptoms which are presumed to be due to hypertonic pelvic floor dysfunction. And this is believed to be due to sensitization of nerves which are primarily conducting pain sensation. So if one were to have a differential diagnosis, is there some way, if a patient comes to my clinic, is there some way that I can kind of quickly make a mental map and see, oh, is it this? Is it that? So let's just take everything one by one. The commonest condition being UTI. which is why, in fact, the title given by USI ISU was, is it UTI? And if it's not UTI, how do we go about proving the diagnosis? So UTI would be obvious from taking proper history. There would be some cause for UTI. But of course, the remaining features mentioned may be absent in these patients, and urine analysis would also give a clue. With previous history, there may be associated vaginitis. Rarely, patients may actually have upper tract UTI rather than just cystitis alone. So all of these give away the possible diagnosis. The real diagnosis would come when you check the urine report. Urothelial malignancy, I would think of that in somebody who at presentation, apart from pain and frequency, may show microscopic hematuria on urine analysis. So again, it comes down to checking the urine report. The three conditions described below, one is high tension pelvic floor dysfunction, pelvic floor hypersensitivity, and non-relaxing pelvic floor. All of these are usually evident on clinical examination, and I will just come to that in a moment. What about two conditions typically seen by gynecologists, one being endometriosis and the other being vulvodynia? The endometriosis patients would have periodicity to their symptoms, and usually they will have period-induced symptoms. Vulvodynia is very rarely associated with bladder distension. And this session, we're talking about ICBPS. And so that is also not too difficult for a urologist who's listening to the patient. Chronic prostatitis is a difficult condition, especially in men, because they may present with identical features, but will have tenderness in the prostate rather than tenderness in the entire pelvic floor, but the diagnostic lines are often blurred. That leaves us with three not so uncommon conditions. Let's work from below upwards. Vesical calculi, every urologist will know how to diagnose those, and there will be some history of calculus disease, and a bladder sonography will give away the diagnosis. Radiation cystitis, you know from history that the patient has had some radiation, usually years and years ago, because it takes a while for radiation to produce those typical symptoms. And genitourinary COX, you have to specifically ask for history of COX or COX exposure in a patient who presents with storage LUTS, but with classic sign of sterile pyuria. Now, after having said all of this, let us understand all these conditions can overlap, and that is where the role of an astute urologist is. So I'm looking for painful frequent urination with urgency because of the pain, but almost never associated with leak. That is a dominant symptom. Pain is relieved by voiding. In fact, they often need privacy of their own toilet to void. They may be dying to pass urine but are unable to relieve themselves anywhere, let's say roadside, for example, or in an area they're not familiar with. They are usually not comfortable using a diaper. They almost never leak in the diaper but prefer to wear a diaper in order to void rather than leak. There may be voiding LUTS, especially in those who have pelvic floor related symptoms such as hesitancy, slow flow, worsening with bladder distension, and they find it more and more difficult to start passing urine as the bladder distends more and more. Dyspareunia may be a dominant symptom in women, as I mentioned before, and some men will describe post-ejaculatory pelvic discomfort. It's often confused with OAB because this is nothing else but storage symptoms, but pain would be one feature which will be present in every patient. As I mentioned, these patients almost never leak, and if at all they use a diaper, that is to be able to void in it rather than leakage. They may rarely present with a retention, which is a small volume retention, and patient describing pain which is totally disproportionate to the bladder volume, which may be as low as 300 ml. What happens with pain in these patients? With progressive pain, the pelvic floor goes into more and more spasms. So it's chicken and egg situation. More the pain, more the pelvic floor spasm, and retention starts. Some uncommon features in history may be childhood dysfunctional voiding, rarely sex abuse, UTI we did refer to because UTI may be the first trigger. Some unpleasant memory associated with voiding or holding urine in the past and maybe with fear of voiding in public places. What can be triggers in these patients? It could be an isolated history of UTI, eating the wrong food, wearing tight underclothes, emotional stress, sexual intercourse, bowel disturbance, and sometimes around the period of perimenstrual time in case of female patients. When we examine such patients, what are the telltale signs that we should look for? There may be a certain type of personality, often they're exacting people, maybe perfectionists, high achievers, very emotional, and all this history may be given by their family members actually. Urologically, no specific clinical feature will be seen in a very typical case of bladder pain. However, those with pelvic floor muscle dysfunction, they might demonstrate local discomfort, extreme sensitivity to clinical exam, intense pain on touch on a vaginal or a rectal exam to the extent that they may not allow you to examine them. There may be trigger points, especially those who present with high tension pelvic floor dysfunction. There may be overall pelvic musculature hypersensitivity. Why do these people, some of them develop pelvic pain with a spasm? That happens because there may be ischemia due to vessel compression of these muscles because of extreme tension in pelvic floor. This can lead to release of bradykinin and sensitization or excitation of nociceptors. What kind of investigation would I do in these patients? I know somebody is going to be covering that. I would simply give them a paper to describe their pain, where with 5 smileys, I ask them how severe is the pain. In my practice, my patients find it a little tricky to take multiple options available on standard pain score, and I don't use that as a part of my routine practice. I always do void record in all my patients and a simple routine urine analysis. If there is persistent microscopic hematuria, that may merit a diagnostic scopy earlier than what it would be in the routine list of investigations for ICBPS. Sono pre and post void is always done in all my patients. And the remaining 2 tests, I have put a question mark. Each of this, I'm sure the next speaker is going to kind of give detailed explanation on these. These are the 2 publications. One of them, of course, co-authors in the first paper is Shivam Priyadarshi and Sanjay Sinha. Both of them need no introduction to the Indian Urological Group. And the next paper, we are lucky to have Dr. Rajesh Taneja as one of our speakers. And I would urge everybody to read both these publications. They came in Neurourology and Urodynamic in 2026. So these are recent papers, and they have led threadbare the entire diagnostic criteria, both clinical and subsequently investigative, in patients of ICBPS, both in men and in women. If I were to give a take-home message, what would I give? Well, it's a clinical diagnosis. And very careful history along with a bladder diary usually will give you a clue. Standard investigations may often be novel, but they help in ruling out other conditions. We know that ICBPS is often described as a diagnosis by excluding other conditions such as UTI, overactive bladder, calculi, or very rarely a vesical neoplasm. High index of suspicion and excluding other entities is the most important issue here. Sometimes a therapeutic trial of correct holistic management will actually give you the diagnosis. So the treatment often kind of reconfirms your diagnosis, and invasive investigations would usually be kept in reserve for those patients not responding to simple initial measures. That is all. With that, I'm going to stop sharing my screen. I hope this has been useful. Thank you so much.
Yes, ma'am. It was a very brief and concise presentation. Thank you much.
Thank you.
So questions will be taking at the end along with the case presentation. I think now next
Yeah.
is
We'll take questions in the end.
now Dr. Rajesh Taneja will be speaking on
Yeah,
approach to a patient with ICBPS complex.
yeah. Good evening, everybody. I think This is a privilege to be here on this platform to talk about what is the, just a minute, can I, all participants. Can you see my
Yes.
slide, please?
Yes, sir.
And I'm audible. Thank you very much, USI, Dr. Surya, Dr. Rohit Upadhyay, and rest of the executives, and welcome Dr. Uttam Mete once again to be here to see you. It was nice. Today we are going to talk my topic. I have 15 minutes to talk about symptoms to phenotype, a modern approach to ICBPS. I'll just do this. Yeah. So in 1978, when I was doing MCH urology, we needed to have the book, the actual book, and the one that we read was 1978 edition, which said interstitial cystitis may present with the end stage in a bladder that has been made irritable by emotional disturbance, a pathway of discharge of unconscious hatred in women. That was quite bad, so I removed that word. But the point is that we were all confused. And from there, I will tell you, this is the history that the first time Philip Sinkfiksik in 1808 coined the term tic dolore of bladder, which means that there was pain in the bladder and they did not know what it was. At that time, people used to cut open to pick up stones from the bladder. And this time when they opened the bladder, they didn't find the stone, but the bladder was inflamed. And in 1886, Samuel Grass used the word interstitial cystitis because the bladder was thick-walled and there was fibrosis through the layers of the bladder, inflammation and fibrosis. And in 1915, Hunner's lesion was coined. And then Magnus Wall described what we all understand the Hunner's lesion today. And Essig in 2007 coined the term bladder pain syndrome, which meant that there was a wider thing rather than only bladder-centric disease. In 2015, so I'm talking about 1886, and then 2015, we have phenotyping. 2021, AI has started being used, and 2026, we are looking at apps for the patient. So this is the distribution of pain. It is lower abdomen, perineum, vulva, clitoris, inner thighs, lower back, and anus. The pain, the point is we call it bladder pain syndrome. So the pain is the central thing. If there is pain, could be discomfort, but there's something, it cannot be like, unlike overactive bladder where the patient will suddenly leak urine or have an intense desire. This is pain or discomfort. So relationship with micturition cycle proves that this is related to bladder. So if the pain is worse just before passing urine, that means the bladder has been filled. There is some lesion in the bladder which has been stretched, which causes pain. And therefore, when the pain is worst just before passing urine and is relieved on passing urine, then perhaps it is the bladder which is at fault, or it is called the bladder pain syndrome. If it is during the passage of urine, then obviously the urethra is the point. And in men, prostatic urethra forms the part of urethra, and therefore prostatitis could be related to this kind of a thing, and urethritis. And if it is towards the end and persists for some time, then in women, it is vaginitis because the acid in the urine goes onto it trickles on the vaginal mucosa, which is, for example, if you can imagine a diabetic elderly lady with poor hormones, then she would have atrophic vaginitis, and acid in the urine is going to cause intense pain, and that the lady is going to report as burning while passing urine. So towards the end of urine, perhaps it's extraurethral. Only with an exception that we know if there is a terminal ureteric stone, which is popping out of the ureteric orifice, that can also give rise to pain towards the end and which persists for some time. Dyspareunia, if it is superficial, it is likely to be vaginitis. If it is deep, then perhaps it is on thrusting of the anterior fornix, which is where the bladder, which is injured or is inflamed, lies. So these are the corroborative symptoms that we are looking at. Obviously, if we are looking at bladder pain syndrome. It has to have a relationship with maturation, and the pain is worst just before passing urine. So this is the clinching statement for bladder pain syndrome. And of course, the confusion was that there was a lot of literature. If you read the literature, mainly coming from America, in the last 50 years, anything that had a pelvic pain and urinary frequency, they thought it was interstitial cystitis or bladder pain syndrome later on. But the problem is they did not mention this point that the bladder pain syndrome means with the pain which increases with bladder filling. If the pain increases with bladder filling, we are dealing with bladder pain syndrome. Otherwise, it could be a lot of things. For example, endometriosis or chronic prostatitis. So duration of symptoms, AUA mentioned 6 weeks, the ESIC mentioned 6 months, but we thought it was 3 months. And as we go through this presentation, you would know that it has been accepted now. As Dr. Anita Patel has mentioned about that meeting, those publications came from that meeting. Cystoscopy by American Urology Association was the fourth line of management, which we disagreed. And then AUA, ESIC, and its Japanese guidelines, they had differences. And then we had our own society in 2015, and our definitions had more differences than above. So the definition that we gave in 2017 was pain or discomfort in lower abdomen and or urogenital area of more than 3 months duration, which is worst on full bladder. This is important, 3 months worst on full bladder, along with one or more lower urinary tract irritative symptoms like frequency, urgency, nocturia, with or without standard stigmata on cystoscopy, which meant the cystoscopy could be normal, and provided another discernible pathology is unlikely to cause these symptoms. So this is the meeting that we had in 2025 in April, where we had IC International Consensus meeting, and we had GIPS was one of the part of the think tank there, along with MAP, ESIC, and ASEAN and NIDDK. And out of that consensus meeting, what emerged was that the definition of ICBPS now contains 3 months duration, and the sentence that the pain on bladder filling. This has been included, and they have accepted to do early cystoscopy, and they have included early phenotyping to begin with. So this is what we have been talking for about 10 years, has now been accepted internationally on that consensus meeting. So this is the paper that Dr. Anita Patel actually mentioned about. And if you see the conclusion says that it worsens with bladder filling and 3 months or more. So this is what we have been talking about in the last 10 years, has now been taken up internationally in the consensus meeting in 2025. So I will talk about urgency a little bit, because this is an urge wave that happens with the overactive bladder. For example, there is a teacher who is teaching, and suddenly she has an intense desire to pass urine. She sits for some time, and then she crosses her legs, she waits for a few seconds, and the wave disappears. This is the classical overactive bladder urgency. Because urgency you can overcome for some time, and that is how the bladder behaves in an overactive bladder. What happens with the urgency of ICBPS? ICBPS, it is a sensory urgency. The problem is that the patient has pain and she doesn't have a desire to pass urine. The patient does not have a desire to pass urine. They learn that they have their pain, which will be reduced if they go and pass urine. So to call it a true urgency is the overactive bladder. In ICBPS, you talk to the patient, they will say, I have intense desire to pass urine. There is so much of pain. But you ask them that, do you think you will leak urine? Are you scared that you will be leaking urine? Then the patient says no. The ICBPS patient will say, I am not scared that it will leak. I'm only troubled because the pain will increase. And the second thing is that if you talk about urgency from sleep, so patient is sleeping well, she wakes up from sleep to pass urine. You ask her, do you wake up with a urinary sensation or do you wake up with pain? If the patient has overactive bladder or a small capacity or something, they will say they wake up because there is a urinary sensation. But patients with ICBPS, they would be scared to sleep because they say that if I sleep off and I don't see that I'm not aware that the bladder is filled up, I wake up with intense pain. So these are two clinching questions to differentiate between overactive bladder and the bladder pain syndrome. And if you are still confused, this is what we define. So there was a talk about potassium sensitivity test with Lowell Parsons. He started that in 1990. And I met him and I told him, why do we want to give more pain? Let us take away pain. And I devised this intravesical lignocaine test. So you put in lignocaine into the bladder and the pain disappears. That means the pain generator is the bladder. That is how you differentiate between various kind of pains if you are confused, if you are not aware, that if you are not able to decide. So we have been improving our guidelines, and the fourth guidelines has also been, now they've been translated into many countries. If you want to have the fourth version, you can please take this QR code, and if you can scan this QR code with your smartphone, you will get the guidelines. Otherwise, you can contact any of us. We will be very happy to give it to you. So what is important, once you make a clinical diagnosis that patient has symptoms more than 3 months, the pain is worse on full bladder, it is relieved on passing urine, there are hardly any leakages, the patient is not worried about leakages, he is worried about pain. So that is the clinical diagnosis of bladder pain syndrome. We still go ahead with bladder diary, urine analysis, ultrasound, cystoscopy, symptom score, quality of life scoring, and phenotype. These are now mandatory as per the fourth guideline. Urine culture, yes. In case we find something in the urine analysis, we get a urine culture. If there are RBCs, we get a urine cytology, and pain map using a pain body chart and urodynamic study in case it is required. So I'm not going to talk about frequency volume chart here, but the important thing here is to exclude the diagnosis of ICBPS. We should have urine routine. If there are pus cells, or if there are leukocyte esterase, or if there are nitrites, this is infective cystitis. And this excludes the diagnosis of ICBPS. Every day I see patients who are brought to me for ICBPS. Steroids have been given, what all has been done. Patient is having full field of pus cells in urine routine. When you talk to them, they say urine culture is sterile. So the problem is you cannot exclude infection with urine culture. The urine routine is the diagnosis of urine infection. Culture is a microbiological diagnosis of the offending organism. And of course, we must do ultrasound in all patients with a residual urine. We can have stones, we can have tumors, we can have other lesions like cystitis cystica or proliferative cystitis. We can give rise to pain exactly like bladder pain syndrome. So cystoscopy is, although not essential for diagnosis, but it is essential to plan the treatment. So unless you phenotype these patients, you don't know how to treat them. So cystoscopy may be absolutely normal in a non-bladder centric bladder pain syndrome. It should never be done under local anesthesia because these are the patients who have gone to pillar to post. They've gone to the gynecologist, they've gone to the GP, they've gone to urologist who has given antibiotics. But when you do a cystoscopy, patient is, remember, the patient has pain on bladder filling. You put the patient in lithotomy and you try to distend the bladder to see what do you expect. You expect pain. The patient is not going to be cooperative. You come out and you tell the family patient is uncooperative. So you doom the patient's future for that. So we need to look at the patient as the initial look in the bladder, and which may be entirely normal, but when you distend, it causes then you can see a lot of findings. And this gives, if giving anesthesia gives you opportunity for hydrodistension and of course ablation of ulcers and multiple biopsies if you want. So Gibbs came up and published this technique of cystoscopy. I recommend highly that anybody who is interested in this subject and wants to do how to do a cystoscopy in these patients, please go through this article. This is really available. And when you do cystoscopy, it could be either normal or there could be non-specific findings like mucosal cracks, glomerations, and diffuse bleeding, and of course, specific finding like Hunner's lesion. So ESIC believed that unless you have Hunner's lesion, it is not bladder pain syndrome, which I think is different. We always thought that patient is having pain, it is a clinical diagnosis. Bladder pain is a clinical diagnosis. If there are glomerations or there are mucosal cracks, or if there are small capacity bladder, then perhaps we are dealing with bladder-centric disease. If the bladder is normal, we are dealing with non-bladder-centric disease. Hunner's lesion is something like this. This is a very old slide, but this is a very early Hunner's lesion. If you see, there is a central reddened mucosal area with a central scar, which is centripetal blood vessels. Rest of the bladder is normal. If you see one, you cannot forget it. So this is what is a Hunner's lesion. It is actually a different disease. We try to talk about it, but we are still, international community still groups it as bladder pain syndrome, which perhaps is now one of the phenotypes rather than a different disease. And then the problem is that when women go to a doctor with bladder or urinary symptoms, they talk of bladder. When men go to a urologist or GP, the doctor feels that the patient has got a prostatic issue. So how do you differentiate chronic prostatitis from bladder pain syndrome? So as I said, pain aggravates during passage of urine in prostatitis. There's really no suprapubic tenderness. A patient who has bladder pain syndrome, which is bladder-centric, you put your hand on the suprapubic region and you will realize it is like very tender. In addition, you can have a tenderness on the rectal examination, and the anterior rectal wall or the prostatic tenderness is very different from the bladder tenderness. And you can really make out whether it is the bladder or the prostate. And if you are in doubt, whenever you do cystoscopy, you can. Now, this is etiology, role of multimodality treatment. I'm not keen to go into it, but all I'm trying to say that there is a urothelial insult, there is a problem with the gag layer, and we need to give a lot of things that need to be, this is not my field, but I brought it because this is what is the genesis of path or the bladder-centric bladder pain syndrome. We need to characterize this. I've been talking about bladder-centric, non-bladder-centric, Hunner's lesion. So we need to know this is the manifestation, but we should know about the etiopathogenesis. So if we were to go through the etiopathogenesis, we have to know about whether there are history of allergies. So a lot of patients who have history of allergies, bronchial asthma, seasonal hay fever, drug allergies, urticaria, they can be reacting to some normal foods which other people would not be reacting to. So, and then that is the allergy kind of background. Then there are patients who have obstructive symptoms, which Dr. Anita Patel has very nicely described in women due to pelvic floor spasm. And these are the patients who have perhaps the pelvic floor or a dysfunctional voiding kind of a bladder. Then if there is a burning character, a lot of patients will come with burning at the tip of the penis when the bladder fills, or at the clitoris when the bladder fills. Now, these are the patients who may have a neuropathic because it is the nerve which is getting traumatized. So in women, 50% of the pudendal nerve, 50% of women will have pudendal nerve when before it enters the Alcock's canal lies very open. And when the bladder fills, it rubs on the pudendal nerve, and the patient has this burning character of the pain, which goes up to the clitoris on both sides, from both sides. And that is what is one differentiator. So the point is, if you take good history, you can actually find out the etiology. Sometimes recent change in diet, like health drinks during
Thank you very much, Taneja sir, for such a nice lecture. And I think questions will be at the end. Now I invite Dr. Sanjay Pandey sir to deliberate on the treatment, particularly the individualized treatment for interstitial cystitis bladder pain complex.
Dr. Rohit, good evening. Good evening to everybody in this esteemed panel discussion that's going to come after this. Thank you, Dr. Anita and Dr. Rajesh, for putting pathways to what we look forward to in future towards a therapy of a very confusing subject in the past, but I think it's opening up with every passing year better than before. The topic you gave me, Dr. Rohit, was precision therapy for IC bladder pain syndrome. Absolutely right. In a era of phenotyping, which Dr. Taneja just concluded around, it looks like that phenotyping is the way forward to move forward in most subjects where we do what you wanted as right approach to the right individual. And when I look into this aspect of care, I obviously would look into taking it forward to the highest possible level. For the needy at crossroads who has been attempted to be treated best globally and has not found the answers in majority of situations around. There was an era when we followed a step ladder pattern. And that is where we woke up to the AUA 2014 guidelines, where everything would be step ladder. If you have this, you reserve it to this and reserve it to this. And that's how the world moved on this subject. While confusions were wrought away and we probably got more and more answers, it was difficult for us to understand that not every patient can be managed who's refractory without doing what Dr. Taneja did talk about in the end, evaluating them to the core, maybe a cystoscopy looking at diagnostic and therapeutic aspects, why diagnosis has already been completed. So treatment modalities, which I'll come to, were not random, but they were all about in a quality of life issue, which is quite getting central sensitized and aspects where the individual and the family, including clinicians and the multidisciplines which touch this patient, required to be apprised about and treating it. There was a huge aspect of therapy which was happening around, and they all have been there. And if you look at it, there was a set of oral medication which you would practice alone or in random, looking at them escalating as required, which we will talk about in your case discussion. Therefore, I don't go deep into it. But everything from amitriptyline to hydroxyzine to pentosane polysulfate to other skeletal muscle relaxants in one kind of phenotype that we'll come to, and gabapentin, other kind of nerve-related aspects of therapy, have been part and cornerstone of oral therapy when individual comes across the table and we revisit our diagnosis or we revisit escalating our therapy to individuals who deserve it. On the other side, there has been intravesical therapies, and then been everything as a solo therapy to therapies which have actually walked into our country, which includes the previous heparin, the lidocaine, which has been both diagnostic and therapeutic in various combination therapies, pentosane polysulfate, which has been a therapy of the past as early as 2011 when there was small RCT of 24 patients to what we now has in intravesical therapy in India right now is pentosane polysulfate. Soda bicarbonate giving a soothing aspect to the cocktails that we have tried have been intravesical therapy aspects. And then we look into surgical aspect of which we all have been privy to treating individuals with different aspects. Cystoscopy and proceed, hydrodistensions, fulgurations, sacral neuromodulations, and then more invasive surgeries of urinary diversions, augmentation or substitution cystoplasties as required. And finally, cystectomies in refractory intractable aspects have also been a part of therapy. So it's all about a step ladder approach. And that's how did I talk about the step ladder approach. But then came the demystifying therapy today on the basis of phenotyping, and it has come to stay. In other words, Dr. Taneja did talk about this important way forward in which authorities, teams, groups have actually taken it forward and brought about etiopathogenesis based, domain symptom phenotype based modification of that, and then the Nichols modification in 2022, and then the map and aspects around. So when you come to this kind of a huge body of work which has happened over a decade of churning on the subject, it is important to probably embrace this and take it to the next possible level. How are we better off compared to what we were in the past is important, because it's great of USI and ISU to have given us an opportunity to me and my colleagues to be looking at the modern aspect of precision therapy where individual and even us as clinicians are confused when a patient comes with overlapping domains around. So thank you USI ISU for having this wonderful program today evening. In fact, before phenotyping, I and my colleagues across the country and the world would look at one size fitting all, empirical therapy, trial and error, reserving the best, giving it later on if required, poor symptom control and frustrated patients, changing clinicians, fraternities and cities and hospitals. Changes have happened dramatically when we looked at hit hard and hit fast and probably bow down to conquer to look at individualized patient treatment plans, mechanism driven interventions, targeted improvements in the outcomes, and finally, high satisfaction, adherence, and patients getting a therapy, which who knows in times to come would be the word called cure, which has been missing in this subject for quite some time. So am I talking about a phenotype approach, which is the precision, the way to go to the piano? In other words, utilize the right buttons, the right aspects, and that is what we look into the what phenotyping was done in terms of diagnostics by Anita and in terms of the evaluation by Dr. Taneja. In other words, we are changing our goalpost over close to few decades of work in the past by authorities, and we take it forward. So there is a paradigm shift, and that is what I would dwell in. We look at the molecules as required in the case discussions. So that it's a heterogeneous disease, and that Dr. Taneja talked about the 25 global census consensus papers, which is a set of papers that one needs to read because the phenotyping is what has changed the therapy that I and my colleagues practice. The important additional phenotypes of Hunner's lesions, low capacity, myofascial pelvic pain, many a times were not known to us or everything was bundled into one. And therefore, phenotyping is clinically useful today. Predictive biomarkers and phenotype specific RCTs may come in the future to make it complete from the incomplete that we may still be there. But today we use phenotype to guide treatment, and that is to bring about precision in the next few slides. So let's look into a little bit of practical approach, which will help our case discussions that Dr. Rohit will bring up. The more difficult one and the more refractory one and the more dangerous ones that they call are the Hunner groups, which have been actually the part of the initial IC word, the cystoscopic findings and the pathological findings of the past. Then comes a non-Hunner bladder centric. Then comes the myofascial and probably the systemic group. Broadly, if we look into that kind of a clinical domain, which we get to see, we have a focal inflammatory Hunner, we have a storage nociceptive bladder, we have a pelvic floor pain generator myofascial, which you pick up by a good clinical examination, again multidisciplinary, and then a widespread sensitization, central sensation, which actually takes a huge toll on everybody, right? From the caregiver to the family, and obviously the patient goes into journey. So the same patient may have more than one active domain, is what we need to take back home. The therapeutic question is not what is the next treatment, but which untreated mechanism is driving the remaining burden, which probably has been left over in individual when it goes through. I'll touch those four phenotypes in the paucity of time, and then we take it forward on molecules as required in discussion that come up. So the best supported precision model ever could be the identifying the lesion, which is called as a Hunner's lesion, and treat the lesions thoroughly the way we can do best. There's evidence existing in the kind of therapies available for this, which is fulguration and intralesional triamcinolone, which are these are guideline supported options available. Obviously, there is intradermal botulinum toxin hydrodistension as another option, and that option stands tall in most of us who do cystoscopy under anesthesia and look at a cystoscopy under partially full bladder to a hydrodistension model where many of these moderate to low capacity bladders will find an initial relief and a confidence building while oral therapies intravasicals walk in, and it also gives us a prognostic indicator of what is happening around. So I look into fulguration intralesional triamcinolone. Fulguration produces subjective improvement of an amazing kind. Triamcinolone equally effective in any kind of a study which could be existing. I just picked up one of them. Fulguration is hugely effective to start with. Obviously, we don't restrict anymore. We need very thin loops. The bladder is already looking quite dicey and nobody wants to perforate. So we fulgurate most of the time on a very low current of 30, 40, 50. We touch it with the surface touch kind of thing, and that works in a spray model. Sadly, the recurrence could be common because we haven't addressed anything which is invisible to our eyes or which probably could be coming up. Long-term series show that many patients require repeat procedures, but they continue to do good. While they do good, we follow them closely looking at the bladder capacity continues not to worsen. So do not label every red bladder as Hunner's disease. Accurate cystoscopic phenotyping markers actually do matter around. When I move forward from here, I look forward to the aspect of Hunner lesion per se, which is what could be a discussion model in one of the cases that may come up. Fulguration and triamcinolone have their own series around. They have been the therapies of the past, and these therapies have undergone changes in the future. In other words, as we take it forward, systemic reviews, meta-analysis, Hunner phenotype differ biologically and clinically from the non-Hunner's disease and appear to respond well to endoscopic lesion treatment on this. Therefore, the academic message today should be going from here onwards is high apparent response rates largely come from observational studies. Let's avoid calling this as level 1 evidence, but we have only that evidence, which is the highest evidence available. When you look into the other bladder phenomena, which is the bladder centric non-Hunners, maybe adequate, maybe low capacity phenotype. The clues are about what Dr. Tanaya said: pain linked to bladder filling, frequency, small voided volumes, nocturia, which is a painful nocturia and painful urgency, and the functional, the voiding diaries talk about smaller bladder capacity, same to the anatomic capacity of anesthetics. So out here, it is a lot about hand holding the journey on every aspect of behavioral modification, education, diet, fluid, strategies of managing it, and intravesical options become the forefront of the entire therapy. Oral obviously work, but we know most of the oral have only got that amount. So when you have a patient who is borderline on the bladder between anything between 275 to 400 kind of thing, and this is gradually going down in a long history of patient around, You will have a cystoscopic hydrodistension, which gives temporary relief for a few months. You're following the patient closely, and you're looking at these patients don't land up in a refractoriness of changing and not having results. Out here, botulinum toxin has stood test of time on two important aspects. One is on the aspect of overactivity that happens as a result of the bladder, and obviously the pain and the pain phenomena arising from the nociception, arising from the trigonal area. And therefore, injection of botulinum toxin of 100 units in the trigone and probably 100 units by many authorities, including Professor Coe in the bladder, has stood test of time on the refractory bladder-centric non-Hunners group around. So the evidence is that in 8 weeks' time, botulinum toxin with hydrodistension has been much better compared to only hydrodistension, and the overall success has been good enough. We understand that the 25 consensus talked about this is condition recommended as an option with or without hydrodistension for the refractoriness of bladder-centric disease without Hunner's lesion per se, where we have got answers of a cystoscopic or therapeutic activity in the bladder. When I come into the myofascial pelvic floor IC bladder pain syndrome group, I understand that this is something where we need to look into this with a lot of pinch of salt. We are all clinically wonderfully in examination aspects around, and our colleagues also, the gynecologists who see more patients than us because majority of women would go to them. Look at pelvic floor tenderness, look at trigger points, look at the myofascial bands, look at hypertonicity and impaired relaxation. And all this helps us to bring a therapeutic target, which is a pelvic floor rather than the urothelium, which was always wrongfully thought about. I won't dwell too much into the slide, but I look into that there's a myofascial therapy compared to a global massage. The myofascial therapy is a very focused therapy, which has got a better response rate. And therefore, in this kind of a phenotype number three, manual physical therapy should be offered when appropriately trained clinicians are available. Pelvic floor strengthening. Kegel should not be done in such patients around, which sadly has been a part of it. And finally, I bring to a situation where there is a difficult patient, a widespread pain phenotype, which is more of a systemic phenomenon. You get to see such patients, which confuses you with many more discomforts and systemic pains around. That means there's a widespread pain, multiple chronic overlapping pain conditions, fatigue, sleep disturbance, a central sensitization, and symptoms from the bladder go beyond the bladder. That means the bladder only treatment is unlikely to address. I need more colleagues on different fraternities to help this full pain burden. Again, a multimodal management and the aspects of care are beyond discussion. We look into amitriptyline and hydroxyzines. But the message here is pharmacotherapy can be a reasonable therapy, but evidence does not establish a very systemic phenotype here. So not one drug fits here out there. Central sensitization is a huge challenge here, and that's something which cannot be handled around. So when I look into that kind of a patient around and look into the kind of yes and no about it, let us do not repeatedly cycle through bladder treatments without reassessing phenotype. If I'm failing on a therapy again and again, on an established therapy, established phenotype, I must revisit the subject. That's how we do in other subjects too. Do not prescribe pelvic floor strengthening to hypotonic pelvic floor. Sadly, it happens, but it's getting down lesser and lesser with the way we are looking at it. Do not present pentosane polysulfate as a high valued therapy for all of them around. It has got for a bladder centric phenomena. Pentosane polysulfate has been a great oral drug. Remember, 2014 onwards, it has been a level 2 therapy for patients on oral therapy and the only oral therapy available. Do not claim one intravesical cocktail to be superior than other. Every patient may respond differently, and therefore we need not conclude to one. Do not use antibiotics chronically because sadly we have now gone into the microbiome era and we've got to be very cautious about looking at that. And let's do not equate symptom severity with a single biological phenotype. So when I come to the close on this with a paucity of time to bring about a phenotype and precision about it, look at a case example where a Hunner's lesion with pelvic floor tenderness with a widespread pain could be a difficult patient tomorrow morning with us. We treat this lesion, we treat pelvic floor and treat a systemic pain by a network that we're looking into. In other words, the bladder centric pain, urgency, frequency, sleep deprivation, and all things which have gone into have systemically made the patient into a situation from where each domain has to be treated separately. Therefore, use a domain based outcome. Look at the symptom complex, go to the most difficult one. The patient looks confidence, hand holding, looking into all aspects of therapy, which also includes the voiding diary and the functional bladder capacity. It also looks at anatomical bladder capacity for future. We all have been guilty about looking at therapies where we found other organs could be problems, and our urology and gynecology colleagues in the past and future may dwell in treating some aspects of the issues around. So I come to a close with the last slide talking about a practical evidence-based precision algorithm which could fit all. Let's confirm by excluding what our two colleagues did talk about: infection, malignancy, stones, and mimics. phenotype them thoroughly well on the phenotypes given to us, score them thoroughly so that we know that we'll be able to show them the subjective and objective improvements, match select therapy according to dominant positive domain, look at the overlapping domains which need a parallel therapy, we combine them together and finally we measure and we look at them not going downhill on a course of a therapy. So friends, as I come to a close, we look at forward that we are stronger than the ancient only because we have been driven by science, driven by the kind of work that we have taken forward in all kinds of practical working guidelines that we look into. Life comes to a full circle. We should be driven to a wake up call for all of us, and we look forward to taking this forward to the next possible level. Rohit, I'll close it here because I'm already 15 minutes exactly. And we look forward to your cases to be discussed, molecules if required.
Thank you, sir. Actually, it was a nice presentation, Hunters, non-Hunters, then myofascial, and then generalized pain. And I really thank all the consultants, all the experts for sticking to the time and completing it in 1 hour. So now I have got 2 or 3 cases. I will share them and hopefully it will solve query of the majority. So this is the first case. I think it is visible. Dr. Surya, is it visible now?
Make it
Yeah.
full screen, full screen.
Yeah.
Now it is visible. Yeah.
So I will not really bore by reading all the lines, but this is a typical 40-year female who comes with frequency of complaint for say last 1 to 1.5 years. She is going to urine around 20 times. Night is also 8 times, and all the time she is complaining about voiding pain. And occasionally she says that the symptoms are relieved with voiding. At times it also persists, and there are other problems also like sleep disturbance is there and daytime fatigue is there. Urgency is not that much popular, though she has been treated on urgency lines for many years. There is no other history which is suggestive of, say, UTI or calculus or malignancy, and there is no any significant past history or any significant other history which is suggestive of any other neurological disease. Examination is also by and large normal. There is no lymphadenopathy. The abdomen is normal. Most important thing is that when you do a pelvic examination, there is no tender point. The vaginas are normal in examination. There is no band. There is no any point of exquisitive tenderness. There is nothing which suggests that the patient has a pelvic floor dysfunction. And even the neurological examinations are normal. Urine routine microscopy is normal. There is no evidence of infection. The uroflow is also reasonably suboptimal. You can say voided volume is only 90 ml with a Qmax of around 9 ml per second. And even the blood investigations are normal. And what the 24-hour bladder diary suggests that she is passing urine around 22 times a day and 6 times in night. Maximum voided volume is around 90 ml. And urgency episodes, though it is present, but it is doubtful. Occasionally it is pain and occasionally it is urgency. Very difficult to differentiate. And the ultrasound is also normal and the bladder wall thickness is normal. The most important thing that when we did a cystoscopy, it was a very typical presentation of a Hunner's ulcers. So what we did a biopsy, we did a fulguration, and then typically what we do is that we started the patient on tryptomer, Atrax, and Pantosan polysulfate for around 6 months. Initially, the patient showed some response. There was some response, 50% improvement in symptom was there. Her pain decreased, even her urgency episodes decreased. But the problem was that even the nocturia improved. But the problem was that after 6 months, it was not back to square one, but she was not very happy. She was telling doctor, again, my symptoms are going back to what it was before. And this is not something which is very uncommon. We do feel initially, especially after hydrodistension, the patients do improve. But when you follow up these patients after 6 months, 9 months, or a year, you do feel that the treatment has not worked as much as you feel. So now this is next question to our experts. Anyone can take this question. What is the next treatment when you feel that it is a clear-cut case of a Herner ulcer, bladder-centric pain, a typical case of interstitial cystitis? The initial management has failed. Hydrodistension, fulguration of the Herner's ulcer. You have given her tryptomer, Pantosan polysulfate, and Atrax. Now next what?
Rohit, let me just correct the whole thing. The treatment has not failed. You did an awesome job by evaluating her thoroughly well and we diagnose her. So if any clinician looks into the kind of evaluation you have shown, I think this is a pitch of evaluation where you picked up a very symptomatic individual a young lady in her life, in the prime of life, who goes through a very rapid course of change, which normally wakes us up that is this one of the phenotypes where the bladder undergoes a very significant change and it's all bladder centric to you. You did a cystoscopy and proved to us that there was a typical Hunner's lesion. I'm going to ask you whether it was only single Hunner's and rest of the bladder was normal. Many a times you see global Hunner's or you see Hunner's on various distensible part of the bladders, number one. You treated her right. You did what could be a fulguration, triamcinolona, whichever it is. But don't forget that the history is replete with the work on this subject with no level 1 evidence. There's a huge amount of work on Hunners because that is what IC was in the past. If there's no lesion, it was non-Hunners, no, not a Hunner, or no, not a IC, otherwise it. So that's why Dr. Anita did talk about IC was a part of the larger conglomerate of BPS. So we never failed on this therapy. I thought we did very well on the initial therapy by picking her up and evaluating her. We also did all that. I think we educated the patient, the family. She understood that there is a therapy at the end of the road. But it's known that this therapy does not bring about a confirmation of complete cure. The possibility of this lesion coming back is known. The very genesis of the lesion has not been known too much, apart from some hypothesis. So I know that she has not failed. You have actually put her on a combination of good oral therapy. You've done a cystoscopy evaluation. You treated her. You got her cured at that point in time. But we know that we need to bring about realistic expectation in these individuals. From what she was 22 times pain driven voiding, not urgency frequency driven voiding, to what she became for the first 3, 6, 8 months was good. So I think the subject needs to have realistic expectations set right by the clinician to the family, to the individual, put realistic goals and probably educate, educate, educate. I think from a point of view from what we did to what we are doing right now, we need to revisit that issue because we now know that she is a bladder centric Hunner's lesion disease. She is that phenotype and that is known to recur. So we need to look at following her very closely. Majority of these patients who have got global Hunner's lesions are a conglomerate where the bladder fulguration on one side and a disease on the other side could actually lead to what probably could be a refractory intractable small bladder capacity years later out of missed out therapy or the therapy does not work with one doctor or many doctors. Otherwise, she is a very well-driven patient. She comes back to the clinician, whoever it is, and she says that the therapy has not worked beyond a point. And you said, yes, that's what it is. We will look at you more closely, we'll watch you more closely. And today we have therapies better than what you were in the past. So that's what my initial take on this subject. We never failed. We did well on this subject. We diagnosed, we proved, we treated, and we'll put realistic goals and we take her forward. And we probably will involve more people as required in the team.
Yeah, Dr. Rohit.
Hello.
Yeah.
Am I
Yeah.
audible?
Yeah,
Yes,
you're
Rohit, yes.
audible.
Yes,
Maybe
Rohit.
the other panelists can take what would be
Can
the next
I
line of
make a
management.
comment, Dr.
Yes.
Rohit?
Yes, ma'am. Surely.
Yeah, so first of all, I totally agree with what Sanjay said that I think you've done extremely well for a lady who was waking up at a volume of 60 and 90 mLs, 90 being her best volume, and everything triggered by pain. With whatever you've done, I think she's done dramatically well. Now she's getting up, as I understand, maybe 3 times in the night.
Yes.
From
But
6, you've said she's getting up 3 times. So now her symptom is predominantly persistent pain, which she describes as better than before. Am I right?
yes.
Yeah.
No, the problem is that after 9 months, her symptoms is regressing back to what it was before.
Sure. But that is where, as Sanjay mentioned, huge amount of counseling, because this is not an infection that you give antibiotics for and the patient is cured, nor is this a stone that you remove and everything is fine. So the disease is known to have waxing and waning pattern, and maybe she needs to introspect to find out what is contributing to persistence of symptoms. In terms of the painkiller management, is it the pain which is bothering her? Is it the frequency which is bothering her? Or is it overall dissatisfaction that she is not cured? And I
I
think
think
each
it is
of
all
that,
the
each of that can be looked into. Could we have a repeat bladder diary? Because you showed us a bladder diary, and we know this is a bladder centric patient. If from several times in the night she's come down to 3 or 4 times in the night, could we have a repeat bladder diary? That would be my first question. And if you were analyzing her pain in any way before, with the help of some kind of scale, it could be simple smileys or it could be
visual
0 to
analog.
10 visual analog. Do we have a pain score whereby maybe she's expecting too much? and maybe she could review her own symptoms sitting with you, maybe involve a counselor, and really have a repeat bladder diary and then take a call thereafter. That is where I would lead.
The only query with that I am having is that we do feel that these patients do improve initially, but later on they start going not to square one, but they have a back gear kind of a thing. So
So can
is
I come in,
yes,
Rohit? Can
yes,
I
sir.
come in?
Yes, sir. Yes, sir.
So this is, as both of them have said, that you've done a wonderful job, but we have to complete this job. So there are two aspects of it. One is the treatment of Hannah's lesion, which you did rightly. The second is to prevent it, which we have not done in your case. I would have
Yes,
done
sir.
it differently. So what we do is, the first step is that Hannah's lesion is an inflammatory lesion. We have to do some adjuvant treatment to whatever we have done in your case. So what I have been doing is, after we have done hydrodistension, ablation of the Hannah's lesion, the pain disappears, the patient becomes quite well, and then we do intravesical installations. What I do is intravesical installations of hydrocortisone and heparin weekly for 6 weeks. Now, this has been published in 2007. There's a complete methodology, 2007 Scandinavian Journal of Urology Nephrology. I can give you the link. That is my paper. And that is how we start working on them. So if you do that, the second part is you have to instruct them for diet, the triggers. We have done nothing for the initiation of this inflammation. So that point which caused the Hannah's lesion in the first place has not been dealt with. So we need to look at that. Can we find out? Can it be that is when I say that you have to phenotype and find out etiology based. So if there are allergies, so you can give atarax for a longer period at a higher dose, add montelukast, which is non-sedative more than atarax. So that is one. Second, you have to warn them that you have to come early. There is a neuropathic pain. Normally, inflammation causes pain. In this patient, pain will cause inflammation. So instead of asking them to come when patient is absolutely bad, tell them to come every month. And if the pain score starts increasing, you have to do something, because you have to cut the pain cycle, because pain, inflammation, pain. In this case, it is antidromic conduction, and pain causes inflammation. So before 9 months, these people will come back at 5-6 months, and then you can do a repeat cystoscopy and hydrodistension. You can do it every 6 months, every 5 months. Whenever the first sign of pain, you should be alert. Look at her diet, look at her food diary, look at her pelvic floor spasm. Think of neuropathic causes, for example, pudendal nerve or others. Treat them. So I have a physiotherapist, I have a dietitian who are involved in this, and they have to be around, and that is how you will prevent. We can still not truly prevent because we don't know what initiated it. What we are preventing is what are the aggravating factors. So diet could be one, bad posture could be one. If there is a pudendal nerve thing, that can be addressed. But Hannah's lesion will keep coming back. There is nothing, no, it's not a new thing. So you can do a repeat hydrodistension, you can do repeat fulgurations, and intermittently, you should also have a look at her urinary routine examination, because there's nothing which prevents these patients, these ladies, to get infection. It can run parallel. So flares, one of the flares could be because of infection. So there are certain dietary things which have caused the flare. So with this in mind, we have been using immunosuppressants for these patients. So it has been used since 1955. So immunosuppression, which can be a local immunosuppression, as I said, hydrocortisone, heparin, you can do that again. Or what you can do, what I've been doing for the last 3 years, which is gone for publication, I hope it gets published soon, is oral tacrolimus. People have tried oral cyclosporin. People have tried intravesical tacrolimus. I have used it for 3 months as systemic oral tacrolimus because there is an inflammatory pathology background which is happening, and immunomodulators in this Gibbs there was a lecture on immunomodulators in the treatment of ICBPS. So these are the things that can be done. These patients are very grateful if you pick them early for the second hydrodistension and fulguration. Very strict with diet. Some people, there was a lady ophthalmologist who had this, and then she came back after 6 months, said, for last 10 days, I've been having some problem. I said, what happened? She said, my son has come from US. And I said, what did he get for you? Did he get some dark chocolates? She said, yes, lots of them. And I've been having, dark chocolates very often in a day. So it is one of the triggers for pain and flares. And we stopped it. We alkalinized the urine and she became fine. So I'm talking about 15 years ago. So you
only
have to
two
be very
questions.
closely related. Yes.
Only two questions. What kind of analgesics, apart from gabapentin and amitriptyline? Because we were treating with that.
Analgesics will not work. I will tell
And-
you, it is alkalize. If it does not change the diet, alkalize. If it doesn't, go back, do a
No, no.
cystoscopy, hydrodistension. burn the
Regarding
lesion.
your choice of analgesics that you mentioned, apart from gabapentin and amitriptyline, anything else you suggest?
Nothing will work. If
Okay.
these are when you have neuropathic elements. I
And
give clonazepam for skeletal spasms, but if they are not responding, then you have to go back and do something.
sir, what is the dose of tacrolimus that you use?
Tacrolimus is we normally give it as to keep a TAC level of around 4. So we
And
do a trough level of 4.
And you also monitor
Is
the
adjusted.
serum creatinine.
Of course, everything, HbA1c, TSH. There's a whole protocol. If you want, I will send it to you. I'm just waiting for the publication
Okay,
to.
Anita Patel madam was interested in asking a question. She was raising her hands. Yes,
Yeah.
ma'am. Patel ma'am.
So I would still go back to our original stand that you've done brilliantly. Repeat a bladder diary, and I do involve a therapist very often. That's very different from a psychiatrist. These patients are not mad, they don't need psychiatric medication. But sometimes we all need some hand holding and we all need some help into looking into our symptoms, counseling, telling them that there is nothing dramatic here. Yes, we know you are suffering, but let's just change our trajectory. Let's involve somebody who might give you an insight into what's happening. And the therapist actually helps them deal with the pain a little better. And it's amazing how it leads to a cycle where they are able to better cope, complain less, and that gives you that much more pain-free period. And we can, reserve higher therapies for disease progression in future again. And then, of course, any of the things which Dr. Taneja has mentioned, each one of them has a very, very definite role. But I feel I would involve patient's mind, involve a therapist, and see if that helps.
In this case,
So-
actually, Rohit, since
Yes.
she responded, I would actually have a low threshold for doing a rescopy.
Absolutely. Yeah.
So we have got 2 more cases, so we'd like to do it quickly. And this is a case I think Dr. Taneja will not agree to it because he always says that chronic pelvic pain is different from IC. I agree to it, but I think this is also a very common scenario, a case which is I am going to discuss now. That I think everybody is following my screen now.
Yeah, go ahead.
It is a 48-year-old male, a software employee, who is complaining of a typical burning pain in a penis while voiding for last 1 or 2 years. And he describes pain in too many ways. At times he say it is a deep pain. At times he says that it is like electric shock. And each time he will come with a different description. But the important thing is that he has got a voiding penile pain. That is the most important thing. And it aggravates during micturition, it aggravates during ejaculation. Occasionally, the pain gets relieved after voiding, but generally, it doesn't get, it is not much of relief after voiding. So, it is not a typical IC patient. And it has definitely the patient has also got some ejaculatory pain. The past history and the personal history is not significant. I would like to go a bit fast. Bit anxious on look. All other examinations are normal. Neurological examination is normal. There is no band. There is nothing which suggests that the patient has a pelvic floor dysfunction. And even the urine routine is normal. There is nothing which suggests that there is a UTI or a bladder stone. Euroflowmetry is also with a Qmax of around 10 Qmax is there. The hematology and all the other blood investigations are normal. Ultrasound is showing a normal. PVR is nil and the prostate is only 18 grams. And this is a typical cystoscopy finding. Something is seen. People can describe it in too many ways, but it definitely doesn't look like a Hunner's ulcer. It was maybe a cystitis cystica, but we took a biopsy. It was non-specific. And we tried all kind of medications, dietary restrictions. We even sent the patient to orthopedician where they advise particular kind of a chair where he can sit. Even a psychiatric consult was done for anxiety management, and the typical management that we give, tamsulosin and sulfasalazine, it didn't improve. Amitriptyline for 3 months. There was somewhat of relief, but still the patient was coming back to us. I think this is something that everybody sees in OPD. Please, any one of you can take lead, because this is not a typical IC patient, but it is a very common problem which really affects each one of us. So Pandey sir, you can start.
Rohit, thanks for putting this case, which confuses all of us at some point in time of our career. And it probably is something which you like to give away to somebody else. Now, this patient is obviously going through this trauma not for day, week, month. There have been symptoms which have been changing. Don't forget that this patient, if you look at the files that he's carrying, has probably spoken also differently to different doctors too. His concern or the primary concern was spoken first, other concerns were not there or were there on a minimal side. So his concerns keep changing. Is he not one who could be fitting into the phenotype of probably a neuropathic with other issues around? Or maybe a systemic kind of a global phenomena, which is more of a central sensitization where you've given him doxycycline and levofloxacin for a possible urethritis when the urine routine was normal. So probably we have not done our focus investigation in these cases around and they linger longer, probably in the past. They may still linger longer because they're fastidious and they want to look at symptom relief. And therefore, if you and I are not able to bring about what Dr. Anita rightly said, a therapy or therapist as busy clinicians, we probably miss the boat. These people then probably change guard and go to somebody else who would listen to them, which has to be a patient listener amongst the busy practices that we may have. At the same time, look into aspect of care which you have mentioned as CBT out there. So he probably is fitting into a partly neuropathic. His amitriptyline must have given him relief. I'm more than sure. The problem, the issues with these medicines is they are dose limiting effects, which are so-called side effects. They probably are not effective to many people. They probably give it up soon. But when we linger with a smaller dose and rise up the ladder slowly and keep building confidence and keep telling them, most of the things are good. That means you're going in a right direction. This takes longer time. These are difficult patients. These are not that you've got a medicine for this and will never come for a medicine for this. Therefore, this is put into another phenotype altogether, a mixed phenotype or more of a systemic phenotype, where I'll put at those confirm and then evaluate and move forward around. So it may not be easy patient around, and all of us will see this regularly. We'll probably go back and revisit our diagnosis in such cases. We may be T-SEC files and we look at labeling each of them as chronic pelvic pain syndrome, chronic prostatitis, and the files roam across the country. But it's important for us to look into that these patients deserve more empathy and looking at targeted, focused, symptomatic relief on aspects that the disease, which means you may land up with polypharmacy, polytherapy, and multidisciplinary care at the end.
Okay. So anyone, something has got a different opinion
Yes.
or something more to add to it?
So can I start, Rohit?
Yes, surely.
I haven't seen the Euroflowmetry chart, the tracing. The tracing. This does not
Tracing,
mean anything. So
Qmax
please
is
let me finish, sir. Let me finish. This is a pain originating from prostatic urethra. The moment the pain starts, the pelvic floor goes into spasm. So it is the secondary dysfunctional voiding. So there are two types of pelvic floor spasm. One, which is the primary, in which even with bladder pain, you will have it. When you touch it, it is painful. But here, It is very specific. The moment the patient starts voiding, the skeletal sphincter contracts, there is an intraprostatic reflux. And there is a difference in the pH each time and the contents of the urine each time. Therefore, the pain character is different each time he passes urine. And that is why he describes it variously. So this pain is actually due to intraprostatic reflux. And that is how it is reflected. It is referred pain to the tip of the penis and the shaft of the penis and in the urethra. So if you do the uroflowmetry, you will find a serrated graph. It is not a smooth graph. It is a serrated graph. His flow is 10, maximum flow rate is 10 ml per second. And, we all know that obviously that reduction is temporary on that day because there was pain. Whenever he starts passing urine, the skeletal muscle sphincter goes into spasm, causing intraprostatic reflux. And this is that condition. All you need to do is to change the pH of urine, change the diet, and give him clonazepam for relaxation of the pelvic floor sphincter, pelvic sphincter. Allow that to happen. You can add an alpha blocker if you think the bladder neck is high, and give him pelvic floor relaxation techniques, or tell him to go for swimming. The moment he starts swimming, when he goes out the first time, ask him, what is the first urination after you swam for 20 minutes? He will tell you, because there is an absolute relaxation of pelvic floor. And these men, these are real cases that I see. These men will come back and tell you, just after the swimming, I had the best urination of my life. The proof of the pudding is in its eating. So this is one case that I can relate to. This is my opinion because you asked me. This is certainly I'm happy to you acknowledge that this is not bladder pain syndrome, but what it is, I have just mentioned to you.
Okay, ma'am, you were raising your hand. Patel, ma'am. Dr. Anita
Yes,
Patel.
so Dr. Rohit, as Dr. Tanisha mentioned, it would be nice to have a flowmetry graph because just a Qmax of 10 really
Yes.
doesn't tell you. It could be an isolated spike. The rest of it could be an erratic flow. That means, relaxation and contraction of external sphincter. And if at all we want to have more investigation, I would do a good MCU first in this chap. Because one of the thought is, why is a young chap having a flow which is definitely slow? You have given him alpha blockers, you've given him bladder relaxants, and everything has given you no relief. Nothing has given you any relief in this patient. In that case, something is not right. So is it non-relaxing pelvic floor? But even to prove that, and these patients, a urodynamic becomes often a wasteful activity. They are unable to void during urodynamics. And if it's the voiding phase we are trying to study, it becomes a complete wasteful exercise. But a good MCU can actually give you delineation of his outlet. And I think that will add some more information because this man has had everything possible. And I think we are just going round in circles. So maybe send him to somebody else. But coming back to the patient, I think an MCU will add some information to what we already know.
I think
I
swimming was a very good trait. Yes, Pawan.
So I tend to ask them if they are worse on days that they are free. Some of them do very well on days that they are busy, and they do worse on days that they have time when they are giving too much importance to. And these people actually do well with psychotherapy. You set them it's not urological. It's more if this history is there.
In fact, this is where good structured biofeedback can actually help, depending on what the MCU shows and what the therapist have to say. These are difficult patients and we all encounter them. So multimodal therapy, multiple specialists coming together, trying to help the patient is the only way forward.
Okay, I think one of the best inputs I got with that, you asked the patient to go for swimming. I have never tried it. Anyway, so the third case, I think it's 9 o'clock. So I will do the third case. It is a very uh, it is something that I wanted to ask. Actually, these kind of findings you see in patients who are having pain and which all other investigations are normal. Like urine routine examination is normal, the uroflow is normal, the patient is having a pain which is suggestive of bladder pain syndrome. How do you interpret these findings? This is not Hunner ulcers. Is it significant or you can just let it go? That is the question to anyone. Yes, Pandey sir, you wanted to tell.
Sorry, Rohit. So just to take it forward, this could be a cystoscopic finding in a very unsuspicious patient who's not complaining of anything. You may do a female cystoscopy, maybe in different stages of menstruation that could be visible. Like you see glomerations in 10 different kind of an aspects and you label it as something. It could just be a phenomena in the bladder which has, it could be very global. It could just be on the trigone too. So this is more of a phenomena as a result of the bladder speaking up something, but there has been no pathology. Clinicians across the world have biopsied this. There are a host of such pictures and videos available which have talked about this being a disease process per se. The cystoscopy was done for something else, not necessarily females, males, young or old. But this has just been a systol. These are more global, like you have shown them. This doesn't look like in trigone, looks more on the posterolateral wall of the bladder. But yes, normally we've seen that in females across studied along the trigone, and we probably related to some phase of the menstruation. We looked at it across the bladder on some patients and thought this is something very alarming, and we call clinicians on the operating table to look at what is what. But there can be no fixed pathology per se on this. Many a times patient would be asymptomatic of this aspect. You're doing a cystoscopy for some other reason too, which could just be a stenting for an upper tract issue. So I'm not able to correlate one single pathology to a kind of a random global phenomena which is seen by us. If somebody could highlight has been correlated if for a
So,
pathology, please.
Can I come in? So Rohit,
yes,
these are small follicles which are very commonly seen in patients with recurrent urinary tract infections. If you have to decide whether they are causing pain, then you have to go back to the definition of the pain. Then you have to go back to the what I said. If you cannot decide, you can put a lignocaine and check, and you do a cystoscopy with the methodology that the paper says. And if you find it, because it is normal, but decompression, it shows some glomerulations or bleeding, it identifies that this is a bladder-centric disease, then you can treat it accordingly. So that is how it is. Per se, these lesions are quite common follicles, we call it, in recurrent urinary tract infection. These are not follicular cystitis. They are follicles of recurrent UTI.
So, Dr. Rohit, these are like those sago grain kind of areas, and if you were to biopsy them, it almost invariably shows chronic, non-specific cystitis. That is what the pathologists will tell you. One thing which I want to tell, if there are any juniors who are in training, this is not GU Cox. Because sometimes people will, bend over backwards to just prove something just because these are little tubercle-like areas. This is not tuberculosis. This is a very commonly seen finding with chronic low-grade, cystitis kind of thing. And whether this is the cause and the patient's symptoms is the effect, I would put a question mark.
okay. I think so. The case discussion is over. Dr. Surya, you have got anything
Yeah.
to say? I
Yeah,
think we are just in time.
very interesting talks, Dr. Rohit, interesting cases. Well, I have a question to all the panelists. So one of the clinching diagnosis finding we say is absent or no growth on urine culture. Cultures which did not grow anything is one of the factors which leads to diagnosis of IC. But the cultures, what we do, we are not able to culture many organisms. We know that urinary microbiome is so, it has got extensive organisms which you are not able to culture. So are we labeling these things which are infections just because we are not able to culture these organisms? If you do NGS in any patient with these kind of symptoms, what you have said, you see so many different types of organisms. So, anyone, panelists?
So, Dr. Surya, thank you. That's a larger question on aspects of what is not visible to the eyes will not be known to us too. We look at only the E. coli and Proteus and Mirabilis kind of picture around. So we may not be able to, the current standards don't allow us to pick up the entire microbiome under routine clinical cultures. So we really will not be able to pick up. There is always They say urine is never sterile, a kind of a language used when it comes to microbiological taxonomy.
Yes.
But when
Yes.
we look into the aspects of care, I always keep giving a very silly definition about even when we brush your teeth, the bacteria don't run away from there, they're still there. Similarly, we're looking at a pathology of defined proportions which actually is treatable and for which we have climbed the ladder to aspects where we can treat. Uh, a UTI which has got symptoms is then progress further on the workup that Dr. Anita did talk about, and we go up the ladder. Similarly, those things which cannot be still cultured will be probably future of RCTs, future of biomarkers, and future of microbiome related therapies, which probably will be a matter of time to come. But at this point in time,
Yeah.
probably what doesn't meet the eye into the number of phenotypes we know we clash on both sides. We probably miss out on that aspect. That's what I think about. Unless there is something very clinically strategic available where we can go beyond and say that this urine is sterile on the routine format, and we still suspect there is something UTI, and you want to do microbiome cultures and start therapies around, which will be probably beyond us
Yeah.
at this point.
Yeah.
If anything
Thanks,
else you
Dr.
want to add.
Sanjay.
Dr.
The word
Surya,
you
also, if we
yeah.
get this kind of culture, I would actually discuss with the microbiologist,
Yeah.
because this is beyond the routine bacteria that we are used to seeing and treating. What we see, does it need treatment, and does it have a cause and effect relationship? So I would actually discuss with the microbiologist, what is this organism? Is it relevant? Is it seen anywhere else in the body? And is it known to be associated with symptoms? Because maybe we don't know about all the microorganisms. We
Yes.
know about the standard titles.
Yes.
So I would definitely discuss this.
Thank you. Thank you. Yeah.
Rohit, can I add a sentence on your first case? Dr.
Yes.
Pawan did speak on a very important aspect we should not miss out. When we picked up a Hunner's lesion of the kind that he showed on the picture, that really was one, we're almost aware that while we give a therapy on this side, we want to prevent, and Dr. Neja did talk in details about what it is. We have a very low threshold on such patients to go back on both the warding diary, which Dr. Anita said, because that gives us a benchmark of when do we trigger the next cystoscopy. But these patients undergo more frequent cystoscopies than any other kind of phenotype, only for one important aspect. Number one, this is the phenotype which actually goes to a refractory intractable small bladder capacity, where a life actually becomes 22 to 42 times per day, and we don't have answers beyond it. So leaving her for 9 months that she has done well will not be a part of our clinical therapy on this patient. Maybe you can leave the other patients too. They are good on the neuropathic, they are good on other phenotypes. They may come back when they want to complain and give them a trigger point checklist they want to come back. But for a patient with that kind of a florid Hunner's lesion, which we picked up quite diligently on the complete workup, I don't think we'll leave her for 9 months and then ask her to again trigger and probably switch a bell on and say that now I'm in trouble. That's too late. Because these are the things which actually go into the bladder phenotype of progression to a refractory state from where save the bladder could be the answer, but that's too late. You'll end up in augmentations and substitution cystoplasties. So you follow them very closely and probably do cystoscopies more frequently. Out here, hydrodistension could be a great way to stabilize them, document all of them in terms of bladder capacities, lesions. Well, lesions may come up. And that entire trial of prevention of therapy is a parallel act that we continue to do around. Very important.
So the take-home message is that the disease are progressive and you have to treat accordingly. So Dr. Surya,
Yes.
I think we
Yeah,
have.
yeah, Dr. Rohit. May I ask Dr. Uttam Mete to give his comments, because he's also one of the editors of this JIP's latest guidelines. He's been here.
Hello, good evening, everybody. I think now you are going to be, this session is going to be over, isn't it? Or it is
Yeah,
already
yeah,
over?
yeah. We
No,
have come to the
anyway,
end.
so thank you, Surya, and I must thank all the speakers. They are well known in this field. At least I know them for decades. Now, Gibbs is more than a decade old, and I can say that when I was also a student or trainee, this interstitial cystitis was the term which used to be used, and we never used to think of this disease, and then we thought that it is supposed to be the disease of the fair lady of the Western countries, but it's not. It affects our ladies and, of course, our males also. And it's a really nice session. So I can say that every time I listen to all of you, I learn again something. And thank you. And thank you, Surya, the ISU chairpersons, and thank you all the speakers. And I hope there will be some sessions there in the USI also. Thank you very much.
Thank you, sir. Okay, I think Dr. Rohit, there are no questions in the chat box which I have. I think we can conclude the session. I thank the convener of the session, Dr. Rohit, for bringing such a nice topic, which is always we discuss, and again there is something more to learn from these. The experts have been really very good. Your talks have been very informative. Dr. Sanjay, Dr. Anita Patel, Dr. Rajesh Taneja, Dr. Pavan Vasdeva. Thank you very much, and I thank all the participants who were attending this session. If you have, by some reason, you have missed this session, you can again go back to the e-learning platform and listen to the talks. Thank you very much. So,
Dr. I will
you,
once
thank
again, thanks to Dr. Anita Patel, Dr. Rajesh Taneja, Dr. Pavan, and Dr. Sanjay Pandey for
Thank
sparing
you.
their valuable time. Thank you.
Thank you. Good
thank you.
night.
Okay,
Thank
good
you.
night.
Thank you, everyone. Good
Good
night.
night.
Good night.
Thank
Night.
you.
Night.